Assalamu alaikum wa rahmatullah. Very happy to be here with our colleagues. I see gynecologists, I see oncologists. Very pleasure. Thank you, Dr. Safi, for your kind invitation. When I saw the time giving to me, I don't know whether it's 45 minutes but I hope it's very long time. But I hope to cover all the role of intervention and the procedure that we are offering and we are doing for our colleagues, the gynecologists. So, as always, it depends on the institute and depends on the type of work you're doing. We try to cover elective rather than emergency. But sometimes, you cannot control. You end up doing only emergencies. So, what's the role of vascular and interventional radiology and the OBGYN? The list is listed is expanding. I mean, every from time, and there are more procedures that we are offering, starting from fibroid, embo, adenomyosis nowadays. For the fallopian tube also, we have a role of recanalization or even occlusion for sterility or for the failed cycles of IVF. For internal iliac artery ballooning prior abnormal placentation, prior C-section. Pre-delivery also, there is an interesting concept coming also in the medical field, embolization of uterine artery immediately prior C-section delivery in the OR. Of course, postpartum hemorrhage and role of embolization in the pelvic malignancies, which includes also post-operative, in addition to the pure elective procedure like pelvic congestion syndrome embolization for ovarian vein and vulvovaricosities embolization, plus others. So, as interventional radiologists, we try to teach our resident that it's very complex. So you have to open your field of view always when you are doing angio. It's sometimes you look for a uterine artery, but again, don't forget the other collaterals like obturator, internal pudendal arteries, round ligament, artery, normal variants like ovarian arteries, sometimes supplying the fibroid you take care of. So it's a we look at it like a brain, like a neuro intervention doing AVM or AVM embo or aneurysm coiling. There are many variants. For instance, the obturator artery, instead of coming off from the anterior trunk of internal iliac artery, it could come from the inferior epigastric artery, which is a branch from external iliac artery. Sometimes, the round ligament, contribute to a major supply, and usually comes off from the external iliac artery. Sometimes there is absence of uterine artery, for instance. Very rare, but it could happen. So the concept of embolization is a very old concept. It came up in 1960. You know that Charles' daughter is the father of interventional radiologists and the father also of all intervention endovascular procedure. First procedure done in 1964 by dilating the superficial femoral artery. From that moment, the interventional radiology being in the market. So what we use our tools, sheath, catheters, wires. This is just part of our daily practice, like catheters. This is 5 French. You could imagine that going into the artery. The embolic material that we are using, starting from permanent solutions like PVA, embozine, bead block, or temporary solutions like a gel foam. Gel foam, if you use it, the recanalization will happen. It's a temporary occlusion, so there will be a recanalization within 6 weeks. And there is a plug and there is coils also that sometimes we are using. what are the contraindications for intervention in general, embolization? In emergency, we don't have a contraindication, even if the patient has abnormal coagulation, life-saving, risk and benefit, so we puncture even with abnormal coagulation. And we use a closure device to close the artery. Even there is a risk of renal failure, so it's a risk and benefit. But for the elective procedure, the contraindication, there is a list of contraindication, like a previous pelvic radiation, for instance, because it increases risk of complication, like a necrosis, kidney disease, allergy, especially the severe allergy to contrast, ongoing infection, abnormal coagulation, or if the patient receiving gonadotropin-releasing hormone analogs, because it causes spasm, so it might fail our procedure. I'm going to talk in the coming few minutes about mainly few procedure, like the postpartum hemorrhage, our role in abnormal placentation by inserting internal iliac artery balloon. Our role, although it's rare, but we can do something in the uncontrollable bleeding during ectopic pregnancy, especially the cervical pregnancy. Our role also in malignancies for uncontrolled bleeding. Also non-malignant conditions, I'm going to talk about it also. Fibroid, and I'm going to end up my talk with fibroid and adenomyosis. So, as mentioned by Dr. Qadri, postpartum hemorrhage is, we define it as if there is a blood loss during the vaginal delivery more than 500 cc, in the C-section more, 1000 cc, or if there is a fall of hemoglobin more than 10% from the baseline. It's classified to primary and secondary according to the time frame. Most common that we are encounter and we are treating is the atonic uterus after delivery. It constitutes more than 70 to 80% of our list of postpartum hemorrhage embolization. Other causes like laceration, returned placental product, invasive placenta, abnormal placentation, virgin sometimes, or if the patient has abnormal coagulation. So in the primary, the postpartum hemorrhage, the success rates in the medical literature, if you are doing it the first time, is very high, it's 86%. If you are repeating it, there is a rule also even to repeat it. It will further increase the success rates to more than 90%. However, after the second trial, probably the success rate will be decreased. Sometimes why we fail, for instance, if we miss some collaterals. In postpartum hemorrhage, depends on the status of the patient, if the patient is stable or not stable. If the patient is stable, we can look for the source of bleeding. We can super-select all the branches. But if the patient is not stable, we treat the patient of the postpartum hemorrhage as like a pelvic trauma. Pelvic trauma patient, we do the procedure within 10-15 minutes from the puncture to close, because it's life-saving. So we embolize the whole internal iliac artery, the anterior trunk and the posterior trunk. We embolize it by using a gel form, a temporary solution. Success rate is significant, very high. But if the patient has an injury, this is a different story. The patient is stable. So why sometimes we fail to control bleeding if there is a collaterals, if there is unilateral embolization, if there is a spasm. Sometimes technically we could get a spasm. We like to receive the patient while the patient before the stage of DIC. Before if the patient severely hypovolemic, the artery will go to a severe spasm. So our failure rate, it might increase. In the literature, the success rate is very high, and although some of the papers has small sample volume, but guide us to do more and more. So it's increasing. The number of patients are increasing with years, but the success rate is still very high. I think the success rate is increasing more and more because of the advancement in the embolic technique. So what's the ideal thing in case of postpartum bleed? We like to treat those cases like we are treating in a stroke. You know, stroke, you have a golden hours. You have only 6 hours to treat, from the door of emergency to the door of the angio suite. You need to recognize the cerebral arteries within 6 hours from the time of presentation. Although just recently the stroke expanded the criteria to 24 hours. But the message is, we like to have we would love to have a quick service, so the patient, as soon as the patient is deteriorating uncontrolled by medical treatment, by, for instance, packing or other alternative, just think about embolization, especially in the institute where there is interventional radiologist. You know, luckily in our country now, most of the big hospitals, you have like 3-4 IRs, and it's a 24/7. It's different than 10 years ago. So we like to treat them like a stroke, like a trauma. You know, if the patient trauma, the surgeon, they call us immediately. So within 10-15 minutes, we are in the hospital, we are in the angio suite, we are ready for embolization. We like to treat them like ICU. You know, ICU, we receive patient is totally dying, you know, and unstable, totally hypovolemic. So it's life-saving. You know, we like to do more and more postpartum hemorrhage. You know, some institute, they provide embolization in the OR. Yeah, OR is probably is good for the gynecologist or obstetrician, you know, because the patient on table, but it has its own requirement. You know, for instance, the OR table has to be compatible with the angio suite, like radiolucent, shouldn't be radio opaque. You know, the C-arm, the resolution of C-arm is very different than the angio machine, as if you are comparing two types of car, Mercedes and for instance Toyota, with no discrimination. So, you know, the machine is very different. You know, if you ask any IR, he would love to do his procedure using angio suite, not a C-arm. You know, but you know, sometimes you have to go inside the OR and do it. I think this is an option. But why not in the future, for instance, having a hybrid OR, you know, and the C-section room, you know, the table is compatible. The CR, it's instead of fluoro machine, it's angio machine. Just things to think about. So this is a patient of in our institute called post C-section. So if you look at the left side, the bigger picture, there is abnormal blush, indicate a bleeding, and on the right side there is less arteries. This is after embolization. It's, if you see it in the lower picture, there is a clips indicating that the patient is post C-section. So immediately we stop the bleeding in this case. Another case that we receive a significant, this is few images from the CT of the lower abdomen, pelvis. There is a significant bleeding, post C-section. Patient immediately rushed to the angio suite. We've done pelvic angio. We embolized immediately the whole uterine artery and some of the branches. Although there was no active bleeding, but even if there's no active bleeding, we don't wait if the patient is not stable. We go ahead and embolize. Another patient who has a laceration of the uterine artery, supraselective on the left up picture shows active bleeding. Patient is bleeding on table. So we embolize, even if it's unilateral, but the rule of thumb for us is you need to embolize both sides, because there is, after delivery, the uterus is very hypervascular. There is cross-lateral collaterals supplying, so you need to embolize both sides. Patient went to stasis after, and patient survived. So what other indication also for IR that you need to remember? It's the abnormal placentation. Abnormal placentation, it can cause failure of placental separation, can cause massive bleeding. Risk factors, as you all know, wide, which most common is a previous C-section, previa, sometimes associated, advanced maternal age, multiparity, or previous DNC. So there are two procedures that can be offered. The first one, we are doing it for the last 13 years in our institute, is prophylactic internal iliac artery ballooning. So what usually our colleagues, the obstetrician, they call us. So and it's very elective, which is the thing that we can plan. We do it early in the morning. First case that we start with those type of cases, 7 o'clock, patient on table. So we insert we puncture both sides, both common femoral arteries, and then we insert balloons into the internal iliac artery. The other interesting concept came up with a few papers in the literature is the pre-delivery intraoperative uterine artery embolization, just before delivery. So this is one of our cases. So what we do, we puncture both sides of the common femoral, and then we go immediately. Try to now, because this is a different concept now. There is a baby, inside. So there is a radiation which might increases risk of childhood leukemia and lymphoproliferative disorder. So what we do in those type of cases, we try to be senior who's doing it, try to collimate, try to use low radiation mode to decrease the radiation as quick as possible, trying also to minimize the exposure, trying to for instance, DSA, the digital subtraction we are now using. So there are few things that we are taking care of in these type of cases. And at the end of the procedure, we have a printout from the machine. We're trying to measure and document, because this is a medical legal issue, that trying to measure and document especially the baby exposure radiation dose. We are very safe. For instance, this patient received 3.74 milligray. As soon as it is less than 10 milligray, it's very safe, and there is no extra risk. So this is a routine that we are doing. Of course, there is a 10% error, could be plus or minus, but even if it increase, it's still below the 10 milligray. Now, what we build in our institute, it's a team of IRs that, and we try to endorse it to our colleagues that you need to check the pedal pulses, you need to check the color because of the anivascular. We've had 3 complications the last 13 years, mainly vascular. Try to check the pedal pulses, color, the temperature. Flushing the sheet is very important. And we try to endorse to the nursing, from our nursing side to nurses taking care of the patient, how to flush, how to use the sheath. Usually we finish the procedure and then it's deflated, so we don't use the balloon unless it's after delivery of the baby. So we've done a study. It's a presentation, as a matter of fact. It's submit for publication using internal iliac artery ballooning. Our purpose to study to evaluate the effectiveness of the internal iliac artery ballooning. From 2011 to 2015, we collected more than 64 cases. 4 cases anyway, it's planned to hysterectomy, so it's been excluded. 60 cases are the one who has internal ballooning in the internal iliac artery, with mean age of 35, with multiparity, and the previous deliveries as a risk of the abnormal placentation. So this is indicate that most of our cases are abnormal placentation, either percreta or accreta, and there is incidence of increasing also previa with as known these type of patients. So as I mentioned, we puncture both femoral arteries. We use a compliant balloon, very safe, different than it's a special balloon that we are using. We try to put the deflated balloon in the proximal internal iliac artery, deflated, and the balloon. The recommendation is we inflate the balloon. It's going to be inflated by our colleagues, the obstetrician, after the delivery of the baby, and before removing the placenta, if the placenta decided to be removed. And we like to keep it inflated for at least 4 hours until the patient is stable. So our technical success rates is 100%. This is the balloon size that we are using. Sometimes we are using big, and so sometimes like 10 millimeters, sometimes smaller, depends on the size of the artery. So in these 60 patients, 63 of them, they got uncomplicated C-section, most of the cases. Some of the group, they got further management. I'm going to go into details like embolization and hysterectomy, or like intrauterine tamponade, or end up with hysterectomy. But our success rate is 63, which is very well acceptable. Probably slightly higher, although it's not randomized controlled trial, but it's slightly higher if you compare it to internal iliac artery ligation. The ligation is even more invasive if you compare it to ballooning. So this is just a continuation of the... so our estimated blood loss in the hysterectomy embolization group is like more than 3 liters, but the uncomplicated case is almost like 1200 cc, which is, I think it's acceptable given those complex type of cases. So we got only 1 complication in these 60 cases, but as I mentioned, after that we've had 2 complications, but it's not in those type of cases. Patient after because we've done embolization, get massive buttock ischemia. It's unusual, but for sure it could happen. So our discussion and our limitation in our studies are retrospective, and there is no control group. At that time, we did not measure the radiation dose, which is, I think, a criticism to our study. Hospital stay, fluoroscopic time wasn't recorded at that time, and the duration of inflation of the balloon is not recorded. So our conclusion that, you know, as soon as there is an interventional radiologist, and if you are dealing with abnormal placentation, it's very highly recommended to use the internal iliac artery ballooning, as it is safe and has very low complication rate. This is a busy slide, but it shows that although these type of studies done where they've used internal iliac artery ballooning and hysterectomy at the same time, but it shows that even some of the studies shows that even there is less blood loss in cases of hysterectomy. These type of cases where there is abnormal placentation with a previa, and it shows that the blood loss is in few studies that it's less, and it shows more effectiveness in the if you are using balloon occlusion, the rate of hysterectomy is less. The other concept which came in the medical literature is the uterine artery embolization. Few articles came up. Intrauterine uterine artery embolization prior C-section for the placenta, abnormal placentation. There is a study published in the JVIR, the Journal of Vascular Interventional Radiology, in 2015. Very interesting. They've done a 79 patient with the clinical success rates of less bleeding is 86%, and there's no major complication. Done in OR, done in using a CR. The criticism against this paper is the high radiation dose. You know, as I mentioned before, you know, because it's a CR, it's you know, doing uterine artery embolization before delivery is much stressful than just inserting internal iliac artery ballooning. So that's why probably the fluoroscopy time is less. Subsequently, the radiation dose is higher. Another paper also came up with the same concept, although it's small sample volume, but sounds this is interesting. Probably we might need like a randomized controlling trial comparing this technique with ballooning, or even comparing it with internal iliac artery ligation, as it's the gold standard. Again, this paper shows that the radiation dose is higher, and the fetal radiation dose is exceeding, it's 17.6, exceeding 10 milligram. But it's again, it's a interesting concept that we have to think about. What other obstetric emergency that we can offer as IRs in case of cervical pregnancy, especially if the patient is not responding to medical conservative treatment? Uterine artery embolization is very safe in controlling those type of bleeding. As you know, this is very vascular, so sometimes you use a methotrexate and it's failed, not responding. So you think about embolization. What other bleeding that we are encounter, especially in the malignancy, cervical, endometrial, choriocarcinoma sometimes, or the gestational trophoblastic disease, or sometimes in the vaginal metastatic disease, non-responding, bleeding, not responding to conservative treatment. This is a case of choriocarcinoma in our hospital, a huge mass with significant intratumoral bleeding. Brought her to the angio suite. We've done angio. If you see the right side image, it's a huge uterine artery supplying the tumor. So it took a long time to embolize because it's very vascular, but at the end it's end up with embolization. This is her after full course of treatment. This is her uterus after 2 years. Another case of cervical CA, where there's a bleeding per vaginum, significant bleeding. The angio shows there is no active bleeding, but it shows extensive vascularity because of the neoplasm, because of the malignancy of this, the nature of the cervical CA. So we end up embolizing the uterine artery and adjacent arteries successfully. So what other things also we are treating? I'm going to end up with AVMs, rare, but we are seeing it from time to time. Adenomyosis and fibroid. In case also of a patient with bleeding dialysis, we have a rule also. So AVM, as you know, that it's classified into congenital or acquired one. Congenital is very rare. Acquired is more common than congenital. It could be secondary to C-section, DNC, infection, rarely retained product, sometimes fibroid, endometriosis, and other malignancy. So this is a patient who had a endovag ultrasound, power color Doppler shows significant vascularity. If you see such image, think about AVM, because sometimes if you have a written product or if you are planning DNC, and if you are doing AVM, keratogen AVM, patient will bleed to death. So always, if you have this significant increased vascularity, think about abnormal vascularity like AVM. So the AVM's treatment of choice is if you want to keep the uterus, is embolization, no doubt. So this is a patient who had AVM, angio suite done, and then we've used a glue, which is a permanent occlusive material. Now fibroid, I know it will be probably a hard discussion to discuss fibroid with who is referring fibroid for embolization. This is good. This is a good number. So I hope that this number will increase after this fibroid talk. So diagnosis, as you know, it's done by gynecologist, clinical, and imaging. Prior to fibroid embolization, it's not enough for us as IR to have only ultrasound. We love to have MRI, MRI, not only MRI also with contrast, because it's very important for the follow-up, to check the necrosis, to check the remaining vascularity. Indication to treat from IR perspective is symptomatic, multipara, multiple fibroids, large, probably I forgot to write, significantly large lesion, recurrence after myomectomy, or surgical poor candidate. Previous C-sections, plenty of adhesions. I think it will be very difficult to do or repeat myomectomy if the patient wants her uterus or the patient desire. I think this number of patients are increasing. Luckily, we are trying to convince them for embolization. So, certain type of fibroid we need to take care of. For instance, large fibroids. 10 centimeter probably I will do. Now, if it's bigger than 10 centimeter, before 2 weeks I received a patient with 25 centimeter fibroid. It's a nightmare for you, and it's a nightmare for us. I refused to do her. I told her there is a risk of failure, it will be very high. I'm going to spend probably 4 hours to embolize. Now, small pedunculated, narrowed based segment used to be contraindicated. Nowadays is not, based on at least 2 studies in the medical literature. Small volume, but it's convincing that this is very safe to do. Submucosal, there is no contraindication to do submucosal, except the patient is, in our community, if the patient is virgin, that's very difficult, because submucosal risk of expulsion is very high. Patient might expel, and so a virgin patient might be a difficult. Hydrosalpinx we used to call it's a contraindication, is not anymore contraindication, provided patient will covered with antibiotic. Patient with IUDs also is not anymore contraindication, based on a paper also by Smith and Lahouli. Lahouli is a famous IR. Most of his papers are fibroid and adenomyosis. It shows that there is no increased risk of infection if you are treating those type of patients with IUDs. What fibroid that we are not recommending? Cervical fibroid. Cervical fibroid has its own niche, because it's not only uterine artery supplying the cervical. It could come from the cervicovaginal branch, it could come from other branches. So it's very difficult to treat, very difficult to achieve necrosis in these type of fibroids. Single fibroid will be very easy. This is in general, I know that there's details, but in general, if I have a patient single fibroid, yesterday I get a patient with 5 centimeter fibroid, myometrial. So this is, she wanted embolization, but I refused. I told her myomectomy is much easier than doing. Now, I mentioned about the XL, if you want to accept it, fibroid, where you have huge fibroids. But we've done we started to do, I've done one case of combined. What do I mean by combined? I've done a patient with medical student with our, I don't know, Dr. Salah is here or not, but we've done her where we've done embolization first, and then he took her to the OR, and then he've done a myomectomy. It was so totally avascular. So this concept also is not a new, but you think about it. If you have a huge fibroid, very difficult for IR, very difficult for the gynecologist, why not combining it? Why not doing embolization first and then end up with myomectomy, especially if the patient wants her uterus to stay. For the large fibroid, 10 centimeter even, there are too many papers showing that it's very effective. There is no increased incidence of complication. However, as IR, you need to, it's a time consuming. We have to use plenty of embolic material in order to achieve complete stasis. Not to forget also leiomyosarcoma. It's very difficult diagnosis, but sometimes the clinical history might guide us that this is not a fibroid, not fibroids, rather it's leiomyosarcoma, especially for sure in postmenopausal patient on tamoxifen a long time ago, or if there's any childhood retinoblastoma, or if there is HLRCC syndrome. So you think of leiomyosarcoma. For sure, this is an absolute contraindication to embolize. Now, what's in the medical literature, and especially the interventional literature, about the fertility? the impairment of ovarian function after UFE, we're trying to usually classify the patient either below 40 or above 40 or 45. So the amenorrhea in less than 40 is 1.6 for that fibroid can cause impairment in the ovarian function. Now for the premature menopause after UFE, again, less than 45 is a small percentage, 2 to 3%. In the old literature, you know, the fibroid in the market, it's in the more than 29 years. The first case done in France in 1988 by Ravina, by chance. Now it's 29. There are plenty of articles in the literature, plenty of respected articles in the literature now. So this percentage came down with the years. You know, the technique of embolization is significantly improved. The embolics is improved, catheters are improved. We know the classification and the anastomosis between the uterine artery and the ovarian artery. Probably before 10 years, if you ask me what's the premature menopause rate, I will tell probably 15% or 12%. Now it's 2 to 3% because if there's, for instance, a communication between the ovarian artery and uterine artery, I will use probably larger embolic material. I will probably go ahead, because again, of advancement of IR skills and techniques, I will probably go with microcatheter and embolize this anastomosis. I will probably use larger particles and then try to diverge the flow. Instead of going to the ovarian, goes to the uterine artery. So the technique is significantly improved. Above 45, we know it's higher, so it could reach to 80%. Interesting in the last few years that there is some sort of observation. There is increased incidence of abnormal placentation in post-fibroid embo. As been mentioned in Ontario cohort study, this is a big study, although it's old, like 2005, but this is a big respected study. It shows that there is a 12% increase of abnormal placentation. It was observation, it was just observation point at that time. Now, this is a study where it's a systematic review of 21 studies, and their conclusion: pregnancy rate following UFE are comparable to the age-adjusted rate of general population. Cumulative rate of pregnancy is 58. Miscarriages is 28, like probably normal population. Cumulative live birth rate is 65%. Another very recent article came up in European Radiology, short and long-term adverse outcome after arterial embolization, postpartum hemorrhage patient, systematic review. Again, the fertility rate is 70 to 80% post-embolization. There is no effect on the IUGR or menstruation. The miscarriages is not increasing. Again, there is a percentage of abnormal placentation post-embolization. There is a study comparing fibroid with myomectomy. Although it's small volume, small number of patients, a little bit old study, but it shows that as IR we try not to do a single. We try not to do a patient who desire pregnancy, the future pregnancy. So we are receiving those type of patients. I will call it the difficult group, where patient might not need a child, but she might change her mind later on. So I mean, comparing apple to apple, myomectomy to fibroid in this point, it might be difficult, but again, it shows that there's no statistical difference between both group. The perinatal result also almost like a comparable between both groups. So what's our approach? This is different than postpartum hemorrhage, where this is pure elective procedure. In the old days, we are puncturing femoral artery, only one side. Some group, they puncturing both sides, both femoral, but we stayed and we keep just puncturing the one side. Nowadays, we shifted from femoral to radial because the patient can mobilize immediately. Vascular complication is less. nowadays it's a mandatory to use a microcatheter. It causes less spasm. It's a mandatory to use a cone beam CT post-embolization. So after we embolize, we do a CT in the angio suite to make sure if there's any residual non-enhancing vascularity, because it might be a source of recurrence. So if there is a focus of non-enhancing fibroid, we try to embolize and more. Trying to use larger particles. In the old days, we are using smaller. That's why the pregnancy rate is the ovarian failure is less. We check for the ovarian supply always, and for the pain control, as you all know, that patient will suffer from the pain post-embolization. It's a different protocol, either spinal, epidural. In our institute, we are using the PCA pump. Nowadays, came up with a hypogastric nerve block, the patient on table, so we could go as IR and do the hypogastric nerve block as outpatient. So that in the future, in the near future, it will be done as outpatient. So in the literature, the clinical failure is ranging from 10 to 20%. I tell the patient, there is 1 out of 5 patient might be either repeat fibroid embolization or she might need a myomectomy. The last subject in this session is the adenomyosis. As you all know, the uterine artery embolization is increasing the last few years in treating symptomatic, especially in this group, symptomatic failed group after medical therapy or failed after minimally invasive surgery. Now, the adenomyosis patient the technique and even the angiographic anatomy is different than fibroid. The uterine artery are smaller. We tend to use smaller particles for embolics, and we tell the patient pain will be much higher than treating a patient with fibroid. There are few articles. One of them, very respected article, systematic review, where they collected more than 511 women. It shows that 83% of patients, they have, in the short term, they significantly improve in their symptoms. However, they fail to sustain improvement in symptoms in quite a number of patients. But this is, again, probably I think we need to do more and more studies. But it's a concept that it's in the market, and it's an option that offered for the patient, especially that we know that the definite treatment for adenomyosis is a hysterectomy. But if the patient still symptomatic, failed medication, and she wants to keep her uterus, this is another concept that we can offer. This is the same study which shows that we tell the patient there is up to 50%. There will be a reduction of uterine volume. The junction zone, it will reduce in a quarter of the patient. The symptoms overall, they improve, and hysterectomy rate will be much less. This is a new study also it's a Dutch group, uterine artery embolization for symptomatic adenomyosis, 7 years follow-up. It shows, interestingly shows that after 7 years of follow-up, 82% after, this is adenomyosis after embolization, it shows that 82% of uterine artery embolization treated patient with the hysterectomy is avoided in 82%. So, ladies and gentlemen, in my conclusion, IR plays a major role in bleeder patient and as a backup for OBGYN in cases of emergency bleeder, as the coverage is 24/7. It's I encourage, especially for the patient with postpartum hemorrhage, uncontrolled, to do more and more embolization. For the abnormal placentation, we highly recommended to use the internal iliac artery ballooning. Not to forget this new concept of uterine artery embolization. For the fibroid, I always recommend multiple symptomatic, especially recurrence after myomectomy, difficult patient, and even in the huge fibroid, and always think about combining these two therapies, intervention and mammectomy. Adenomyosis, I think there will be a role in failed medication, failed minimally invasive surgery prior to hysterectomy. Thank you so much.